What's up, Ninja Nerds? In this video today, we're going to be talking about ear infections. And again, this is part of a clinical medicine series. And if you guys are liking them, you're enjoying them, they're making sense, they're helping you, there's a couple things that you can do that really goes a long way. One, hit the like button. Second, smash that subscribe button. And also, I think just leave a comment down in the comment section if you have any questions or if you really do enjoy this video. We'd appreciate it. Also, for your overall edification, for I think truly taking you to the next level, we do offer some other premium services. We offer a lot of high yield notes, great illustrations to follow along with me as we're going through this lecture, some quiz questions to allow for spaced repetition, some flashcards that I think aid in that process. All of those things can be checked out on our website if you go down in the description box below. All right, without further ado, let's get into ear infections. When we talk about ear infections, it's really just coming down to two. One is an infection of the external ear. We call that acute otitis externa, and then an infection of the middle ear. So we call that acute otitis media. You're probably like, oh, is there one of the middle ear? I mean, the inner ear? Yes, there is. We're gonna talk about it. It's more likely to be a complication of acute otitis media, but we'll talk about something called labyrinthitis, and there's another one that we'll mention briefly called vestibular neuritis, and those are kind of more infections, particularly of the inner ear. But we're going to focus on these two primarily, and you'll also see this a lot more, particularly in the pediatric population. We'll explain why. When we talk about acute otitis externa, really it's an infection of the external ear. That's really all it is. It's an infection of the external ear. What really happens is that you have skin. It's a stratified squamous epithelial tissue that lines the external ear canal, the external acoustic meatus, whichever one you want to call it. What happens is whenever you have a breakdown of this skin and cerumen barrier, that's really the trigger. And so let's actually write that down. There's a breakdown in what thing? It's a breakdown in the skin and the cerumen barrier. And basically, this is the barrier that prevents, bacteria, which is the primary culprit, from getting into like the soft tissue and causing an infection. And so that's the primary kind of initiating trigger here. And we'll talk about some risk factors for that. But there's a breakdown in the skin cerumen barrier. When you break that down, the potential issue here is that once you get breakdown, you allow for a lot of bacteria to thrive, to get in there, to cause inflammation. And so what happens is you get inflammation of the external acoustic meatus. So let's actually write that down. So now you're going to get inflammation. So inflammation of the external acoustic meatus. Now this thing's going to get inflamed, right? So you have a trigger. The trigger is there's something that breaks down this barrier. After you break down the barrier, bacteria can kind of get in there. They start kind of initiating some inflammation. When that inflammation kind of occurs, now you get swelling. You're going to get some swelling of this external acoustic meatus. Now look at this. You got the breakdown, and then now you got this swelling. From here, we're going to represent the swelling by this thing being red and angry. And now it's all red, it's all angry, and it's bulging into the lumen of the external acoustic meatus. So now, because of that, here's the next thing. The next thing is that this inflammation traps fluid and bacteria into this like little cave. So now a bunch of fluid can kind of start sitting in here. So now a bunch of fluid can start sitting in this area. When that fluid sits in this area, guess what else can sit in that area? Bacteria. And now bacteria can start kind of populating in this area. And if they start populating in this area and growing and growing and growing, guess what happens? Imagine this. Bacteria love when it's a very moist environment. Yeah, I said moist. It also loves it when it's very dark, right? Guess what's kind of blocking light from getting in there? This massive obstruction of the ear canal. And also, you know what cerumen does? Cerumen actually helps to control your pH of the ear canal. And guess what? When you break down that cerumen layer, you alter the pH and you make the pH a little bit more alkaline. So now the bacteria has a dark, wet, and alkaline environment. Perfect conditions for this thing to grow. So what's going to happen is you're going to get an increase in the bacterial growth. And that increase in bacterial growth eventually becomes enough to make worsening inflammation and now infection. So you're going to get increasing bacterial growth, and that increasing bacterial growth is going to do what? That's going to lead to a ear infection. And that's particularly of the external ear canal or the external acoustic meatus. And that's what I really want you guys to think about. Is again, there's something that's causing a breakdown of the skin cerumen barrier that causes inflammation That inflammation obstructs the outflow of fluid and bacteria. They grow, they grow, they grow, and then they start to infect this tissue. And that's really the crux of all of this. The question then becomes is what's causing the breakdown in the skin ceramin barrier? So if I actually zoomed in and actually took a look, here it is. I'm breaking down that ceramin, I'm breaking down the skin, and this is a perfect opportunity for some of the bacteria that are sitting in this area to get in there. And then whenever they get in there, they start causing injury. When they cause injury, they cause more inflammation. As they cause more inflammation, you obstruct the ear canal. As you obstruct the ear canal even more, you block more fluid. You cause a dark, wet, and alkaline environment. More bacteria grow, and eventually this thing becomes angry and infected. And that's what we see here in this scenario. But we have to ask ourselves the question, what's causing the breakdown there? What is the particular risk factors for certain patients that are causing a breakdown in the skin ceramin barrier? One is you have too much moisture. And what that moisture does is it strips the ceramin layer off a little bit. So too much moisture is definitely a problem. Also, with a lot of moisture comes a little breeding ground for certain types of bacteria. Do you know which types of bacteria love moisture? Pseudomonas. And that's one of the big things, and we'll talk about that. But there's two kind of scenarios, and I'd say the first one is the classic clinical vignette. This is a person who's swimming a lot. Swimming, snorkeling, anything like that. We'll even put snorkeling, I don't know. Anything where there is a constant exposure of moisture in the external ear canal. Another one is extremely humid climates. That's another opportunity, especially if you're kind of blocking that off and putting in earphones, that can create a humid environment as well. The other one is skin injury. So anything that's kind of injuring the skin, especially in combination with that heavy moisture, that's enough to also create an opportunity for a breakdown in that skin ceramin barrier. So either we're breaking the skin down because we're injuring it, or we're stripping the ceramin away by causing a lot of moisture to build up. What are some simple things? It's not complicated, guys. What can cause skin injury? I mean, we tell you sometimes to be careful using these, but cotton swabs, right? So you're picking at your ears with these cotton swabs. Sometimes those can cause some abrasions of the ear canal. Not too big of a deal, but in certain scenarios, especially if there's excess moisture, it can create a breakdown that can cause this event. Another thing is anything that's causing constant abrasion consistently, especially in elderly. Hearing aids. And the last one I'd say is any kind of scratching. This is like probably one of the perpetual cycles for kids. A kid goes out, swims, strips off the ceramin layer. They have a lot of fluid in the ear. What's their natural reaction? To pick at their ear. They scratch that ear. When they break the skin and they have a lot of moisture, that creates an inflammatory event. More fluid, more bacteria, infection ensues. Question is, and why it's important, is what are these most common pathogens that brew in this external ear canal? The most common by far is going to be Pseudomonas. This is the one that I really want you to remember. This is a gram-negative bacteria. By far the most common, all right? Most common. Another one, especially with the skin injury, especially if you're picking and it's on your finger, it's on your skin flora, is Staphylococcus aureus. It's rarely ever MRSA. It's usually almost always MISA. So that's another potential one. But I want you to definitely remember Pseudomonas. Now you may be asking, Zach, what's the deal of us knowing the bacteria? Isn't that more like step one? Isn't that more basics, like microbiology? Yes. The reason why Pseudomonas needs to be treated properly with some type of aminoglycoside or a fluoroquinolone. And that's what we always want to think about is why do we need to know the pathogen? Because it guides the most likely antibiotic that we need to treat with. That's crucial to infectious disease. So to recap acute otitis externa is there is some type of breakdown in the skin ceramin barrier. These are the risk factors. Most pertinent is going to be the moisture with swimming and snorkeling, combined with the skin injury like scratching. That breakdown leads to them things, again, causing inflammation of the external acoustic meatus. That inflammation is going to cause an obstruction. That's going to block fluid. That's going to block bacteria. It's going to create a humid, dark, alkaline, and moist environment for bacteria to grow. And eventually that will infect the ear canal. What are those bacteria? These are the ones. What about acute otitis media, a middle ear infection? Again, when we think about anatomy here, here's our pinna, right? Here's the external acoustic meatus, and then here we have some bone, and then here we have the temporal bone, and then here we have the tympanic membrane, and then here we have the middle ear. And in the middle ear, we can appreciate some ossicles. We have some holes here. This actually can lead backwards and behind into the mastoid sinus. And then here we have the inner ear, which is consisting of the cochlea, the vestibule, the semicircular canals. And then here we have this portion of the vestibulocochlear nerve popping out through the internal acoustic meatus, right? And then there's another structure here which actually appears to connect the middle ear into this area over here, which I'm going to label here for you. This is called the nasopharynx. So you're probably going to ask yourself the question, what is this tube that connects them? Because it's super crucial. This is called the Eustachian. This is called the Eustachian tube. Now, another name for it could be the pharyngotympanic tube. Another name could be the auditory tube. Either way, this is going to be called the Eustachian tube. Now, the importance of the Eustachian tube is that it's supposed to equalize the pressure between the nasopharynx and the middle ear. We want that constant ventilation and equalization of pressures to occur. That's super crucial. What happens though if I cause some kind of obstruction? Let's say, for example, this Eustachian tube becomes inflamed. So I'm going to kind of inflame this and I'm going to obstruct it a little bit here. So now I'm going to inflame it and I'll represent this as inflammation. I'll make it a little bit red. So here's a scenario where I inflame this son of a gun, this Eustachian tube, and now I obstruct that. I'm blocking the ventilation of air between the middle ear and the nasal cavity. And that's going to affect the pressure differences, and it's also going to block secretions that are supposed to drain out of the middle ear. Okay, what if I have something that's obstructing the middle ear? I'm sorry, the Eustachian tube. So there's something here in the nasopharynx that's blocking. And so normally it's supposed to allow for ventilation to occur back and forth. But again, you're blocking this type of movement. And so because of that, if I'm blocking that movement, that's another scenario where the Eustachian tube becomes, if you want to think about it, obstructed. The disease process that often is the trigger for acute otitis media is a problem with the Eustachian tube being obstructed. All right, so it's usually some type of Eustachian tube obstruction. Now this can be functional or it can be literally some type of anatomical obstruction. So we have some type of obstruction of the Eustachian tube. If that's the case, what happens is I lose the ability to equalize the pressures. And so what happens is you're supposed to have naturally some secretions that are supposed to move out of the middle ear. That's how it's supposed to happen. But now that's going to be obstructed. It's going to be blocked. And so what happens is I start to build up fluid. Fluid starts accumulating in the middle ear. And this is called an effusion. So I'm supposed to be draining the middle ear secretions out into the nasal cavity, but I'm not now. And I'm supposed to be equalizing the pressures, I'm not. And you usually know what happens is because this is blocked, you get a negative pressure that occurs inside the middle ear and it kind of sucks on the tympanic membrane. So sometimes it can actually cause the retraction of that tympanic membrane a little bit. So Eustachian tube obstruction creates what? It decreases the ventilation of the middle ear. So now we're going to have decreased ventilation of the middle ear and secretion drainage. So we're going to have decreased ventilation and we'll call it drainage of the middle ear. The problem with that is that now if I can't get some of that fluid out of the middle ear, it accumulates. And you can get what's called a middle ear effusion. Now we have fluid that's sitting in the middle ear. If the fluid sits in the middle ear too long, guess what else should actually be there? It's a part of our flora. It's a naturally occurring flora in our actual mucosa, bacteria. The bacteria can kind of start to sit there for a little bit, and they start to get more stasis. And eventually this bacterial growth occurs, and then this fluid becomes super infected. And now we have acute otitis media. So what starts to happen is that we get a bacterial stasis that occurs in this effusion, and then it starts to grow, and eventually that fluid becomes infected. And then we end up with a infected middle ear fluid. And that is usually how this type of process occurs. So again, we have an obstruction of the Eustachian tube. You can't ventilate or drain the middle ear properly. Pressure gets negative inside of the middle ear and pulls and retracts on that tympanic membrane. Also, the fluid can't get out, so it builds and builds and builds. You get an effusion. The bacteria is sitting there, and it grows and grows and grows. And then eventually, it triggers an infection of that middle ear fluid. The question that you have to ask yourself then is, what in the heck is triggering this eustachian tube dysfunction? What's obstructing it? All right, so there's two potential scenarios that are most often the case, and then there's a universal concept. One is there is inflammation. I told you there was two scenarios. Inflammation of the eustachian tube, which we're going to represent as ET, or there is a obstruction, like an anatomical obstruction of the eustachian tube. So we'll put, and I'll actually put here anatomical. So something is physically obstructing it, and one is causing inflammation that's obstructing it. What are these scenarios? This is going to be two of them, and one is extremely, extremely common. And if you don't remember any of these, you have to remember this one. A viral upper respiratory tract infection is going to be by far the most common cause. So what happens is a person gets like an adeno infection, so they get adenovirus. When they get adeno and they get that viral upper respiratory tract infection, it inflames parts of the nasal cavity, the mucosa, and then guess what? The eustachian tube. So now this eustachian tube becomes inflamed. If it becomes inflamed, it causes all of this process and then allows for bacteria to superinfect that fluid. That's the issue, my friends. Another one is a similar situation, but it's a little bit more chronic. And that's in patients who have severe allergic rhinitis. If you have severe allergic rhinitis, or even rhinosinusitis, these are opportunities for inflammation of that eustachian tube. So that's another potential scenario. The obstruction is usually something that's obstructing the outflow, the exit of the eustachian tube. What would obstruct this? So what's in my nasal cavity? Okay, trying to think. What if I got some polyps, bruh? Oh, that would definitely do it, right? So nasal polyps would definitely be one trigger. And another potential trigger that I would want you guys to think about here is going to be usually some type of adenoids. So if a patient has really enlarged adenoids, that can definitely be a trigger. So enlarged adenoids. So these are your tonsils. So you know you have your pharyngeal tonsils, you have your tubal tonsils. If those things are getting super enlarged and hypertrophic, it's going to obstruct and block that outflow or the exit of the actual fluid getting out of the eustachian tube and into the nasal cavity. So either you got a nasal polyp that is obstructing it, or you have a very enlarged tonsils that are blocking it. So that's what I want you guys to think about. The last scenario is just a general universal concept that exists across the board, and that's pediatric patients are very high risk. So pediatric patients are high risk. And you're probably like, okay, what the heck does that mean? Their eustachian tube is affected because it's just anatomically at a disadvantage to adults. What I mean is that normally in an adult, they have at least more of a vertical orientation of their eustachian tube. That allows it easier for things to be able to ventilate and drain properly. That's one thing. Pediatric patients, they have more of a horizontal endotracheal tube. So let's write that down. They are high risk because they have a horizontal endotracheal tube, eustachian tube. The other thing is that they also have a eustachian tube that's a little bit less rigid. In adults, theirs is a little bit more rigid, so it's not easy for it to collapse. In pediatric patients, it's a little easier because it's not as rigid, it can collapse more. If it collapses more, that can cause an obstruction. So that's another thing, horizontal eustachian tube, and it's less rigid. And then also just another disadvantage is it's short. And it's a little bit longer in those patients who are a little bit more of the adult range. So this is why patients who are at higher risk of developing middle ear infections are pediatric patients, generally. And then if you add on top of them getting a viral upper respiratory tract infection, an allergic rhinitis, or they have nasal polyps, or they have enlarged adenoids, that increases their risk even a larger fold. This is a general universal concept of why pediatric patients are at higher risk for acute otitis media than adult patients. Either way, the overarching theme here is that a patient who has eustachian tube obstruction triggers this. The other thing I want you guys to remember is when you drop the ventilation of that middle ear, it does create a negative pressure. I told you that, and that kind of sucks the eardrum in. But what happens is as you start to build up an effusion and you start to build up fluid, the pressure starts to rise and it actually can bulge the tympanic membrane out. And that's one thing I want you to remember. is that generally with this decreased ventilation, what happens is you get retraction. Initially, you may get some retraction. You get a little bit of retraction of, I'm going to put the tympanic membrane, the TM. Then what happens is this middle ear effusion, it starts to build up and build up and build up. And what happens is over time, this switches it. And this tympanic membrane goes from being retracted to bulging. And that's primarily because of that effusion accumulating over time. As more fluid, more bacteria, more swelling, more pressure builds up. What's it gonna do? This is a critical thing. Eventually, it's gonna push this tympanic membrane out because the pressure is so high, it wants to get it out. And that eventually can lead to ruptures, and I'll talk about that later. But this is gonna eventually cause a bulging tympanic membrane. And we'll talk about why that's so critical because it aids in the diagnosis. So again, what will eventually become a very critical thing here is that tympanic membrane will bulge. Initially, it will retract, but eventually what happens is the fluid accumulates, it bulges. All right, next thing here. We got to talk about the bacteria because again, it's usually a viral upper respiratory tract infection that triggers this. So what we could say is, here's what I want you to remember. There is an important kind of like, I'd say note or connotation to take away from this. And that is that usually acute otitis media is a mixed infection. So it's usually, I'd say 70% of the time, it's a mixed infection. And what that means is it's both viral, because what's the most common trigger? What is the most common one, guys? It's a viral upper respiratory tract infection, usually like an adenovirus or a rhinovirus. And then it becomes super infected, that fluid, with bacteria. And that's where we get the bacteria come into the play. We don't give antibiotics for viral infections. We don't give antivirals for a viral upper respiratory tract infection. We give antibiotics when there is a super infection in certain scenarios. What are those bacteria? Because it determines what type of antibiotic I need to treat with. One, and a very common one, is called Streptococcus pneumonia. And that is usually going to be this gram-positive bacteria. Then we have a coccobacilli, and that's called Haemophilus influenza, commonly written as H flu, and this is the non-typable. And the last one is kind of more of it's a gram-negative diplo, and this one is called Moraxella catarrhalis. So Moraxella catarrhalis. Now these are going to be the most common pathogens. One thing I wouldn't forget is always consider, I think it's always beneficial to consider anaerobes. These aren't always the case, but I would definitely consider them, all right? So with that being said, what do I know now? I know that acute otitis media is Eustachian tube obstruction from these particular scenarios. Almost always universal for the pediatric patients. Add these onto it, you worsen the obstruction. You worsen the obstruction, you decrease the ventilation and drainage between the middle ear and the nasal cavity. But the biggest thing is that you're going to decrease the drainage. If I decrease that drainage, I get effusions. If the effusion becomes infected with bacteria, I then have a middle ear infection. That negative pressure initially, because it becomes negative pressure because I can't ventilate, what happens? Retracts the tympanic membrane. But eventually, over time, as the effusion builds, it bulges the tympanic membrane. Is critical. What are the pathogens that usually trigger this? It's these. But oftentimes, more than not, it's usually a mixed infection, and that's pretty critical. All right. Now what I want to talk about is, now that we got the kind of the overall patho, the causes or the etiological factors, how will these patients generally clinically present? So with acute otitis externa, it's super easy. If you got a red, angry, inflamed, and edematous ear canal, what's it going to do? It's going to cause otalgia. So otalgia is usually going to be the most common type of presentation. All otalgia is it is ear pain. And you want to think about this I think what's also really common is because there's so much ear pain, that can extend out to the pinna. So sometimes the pinna can also become pretty inflamed and edematous as well. And that's very sensitive. There's a lot of nerve fibers that actually innervate the external ear. So because of that, one of the things that we actually like to do here is what happens when you actually pull on the pinna or push on the tragus, which are a part of the external ear. Because those are inflamed and they're very innervated heavily by things like the facial nerve, the trigeminal nerve, the vagus is going to be in the ear canal, the glossopharyngeal. What happens if I pull on the pinna or push on the tragus? it worsens. So an increase in pain and an increase in pain when I do what? Increase in pain with pushing the tragus. That really kind of signifies more of a concern for otitis externa. Or increased pain with pulling the pinna downwards. So all I mean is, patient comes in, oh man, my ear hurts. Wow, ah! That's one thing. Or you push, ah! Those are potential triggers to make you think about otitis externa. Another thing that's also really important is that, again, what are they doing? They're obstructing the ear canal. All of this infected fluid is building up proximal to that obstruction sometimes. So what may happen is some of that fluid may want to leak out through this small little narrowed space. And whenever that fluid starts kind of leaking out, or you even see it in the ear canal, what would that be called? Otorrhea. All it means is it's fluid draining from the external ear canal. So otorrhea. Now otorrhea is normal in otitis externa. It is not normal in a patient who has otitis media. What that means is if they have otorrhea, they perforated their tympanic membrane because the fluid's here. You can't get that fluid out if there's a structure there blocking it. So otorrhea really helps with a concerning feature to diagnose more of that otitis externa picture. But if you have otorrhea, take a look. Look at the tympanic membrane. Is it there? Is it visible? And is it perforated? That may be their explanation. Now, in a patient who has otalgia and they have otorrhea, you want to look at their ear canal. So you want to get out your otoscope and you want to take a look in, you want to kind of pull down and take a look and see what I see. Generally, what you're probably going to see most often with otoscopy is you're going to see a very inflamed ear canal. That's pretty much, it's going to be a red and inflamed ear canal. That's really going to be the biggest thing. You may see a lot of the pus and the otorrhea there present. The key thing that you also want to note, and you have to document these things, is the tympanic membrane. Is it a normal tympanic membrane, or could you visualize it? Oftentimes it's a normal tympanic membrane, but it may be so swollen and so edematous that you weren't able to see the tympanic membrane. All right, so that's the key thing, but the hopeful goal in this is that you can pick out a normal tympanic membrane. It's not bulging, it's not red, and in this case, their external ear canal is super inflamed and red. That's the key thing that you want to note, is that it is normal. But sometimes, I think it's important to note, it may be so inflamed that you can't even visualize the tympanic membrane. But that's what you want to notice. Now, this is the classic presentation of otitis externa. It's not that hard. Where it gets scary and it gets complicated is when it actually extends a little further. We'll talk about this a little bit later, but there is a patient population that is at super high risk of the otitis externa extending past this into what we get worried about is extending into the bone. If it starts to extend into like the deeper soft tissues, the bone structures, that's when we worry about a condition that we'll talk about a little bit later called malignant otitis externa. In this one, there's a certain patient population that you want to consider. It's usually the uncontrolled diabetics, the immunocompromised patients who come in with way more severe ear pain than general. And maybe they also come in with some other concerning features, but we'll get into that a little bit later, all right? So acute otitis externa, what are you looking for? You're looking for the right clinical scenario, and you're looking for otalgia that can be precipitated and worsened with maneuvers, and maybe otorrhea, but big thing is a normal TM. Sometimes it can't be visualized and the ear canal is super, super inflamed. And then in certain patients who are at high risk, you want to monitor them for the risk of them developing malignant otitis externa. Okay, what about for acute otitis media? With acute otitis media, what you're going to have is there's nerves. Again, there's still nerves, cranial nerves especially, like vagus nerve, glossopharyngeal nerve. They also help to innervate a part of the middle ear. And so this is going to cause pain. You're definitely going to get pain here, and especially if it's pushing on the tympanic membrane. So otalgia is usually a very, very common presentation. It's going to be that ear pain. But it's going to feel a little bit deeper, and the type of sensation that they often complain of is that their ears feel full. It feels full, and that's the effusion, all right? What happens here with the otalgia is that it's not worse. So let's actually write this down. The otalgia does not get worse with the maneuvers. So it is, here we'll write it in big capital red letters, not worse with pulling of the pinna or pushing of the tragus. Not worse with pulling pinna or pushing on the tragus. Sometimes, funny enough, is a kid who gets this, they'll constantly feel like they have to pull their ear because it feels like they're helping to open our kind of like help with the inexflation to kind of help to equalize that pressure between the middle ear and the nasal cavity. So sometimes you'll actually notice that the kids will be tugging and pulling at their ear a lot. When a patient comes in with ear pain, external acoustic meatus, usually anything kind of like prior or before the tympanic membrane, won't really precipitate a fever unless it's spread into the deeper tissues in the bone, like malignant otitis externa. For acute otitis media, they do present with a fever. And this is because whenever you have a fever, this really is it's a sign that the infection is extended beyond the ear canal. All right, that's really, really critical. So the presence of a fever, anything greater than 38 centigrade, is concerning for a patient having an infection beyond the external ear canal. And that's, again, malignant otitis externa and acute otitis media. So that should really make you consider that. The other thing here is, it is not common, we mentioned this before, otorrhea is a plus or minus, all right? And what I mean by that is that if they have otorrhea, then you need to say, okay, could this be otitis externa? How do I know that? I have to look into the ear canal, look to see if it's inflamed, and what do I need to note? What's the tympanic membrane look like? In this situation, if they have otorrhea, what that means is that they probably have a tympanic membrane perforation. And that's a complication that can occur as a result of this kind of condition. All right, so tympanic membrane perforation, we'll put perf. Usually what would precede this is the patient will say, man, my ear was really, really hurting. All of a sudden I had this like sudden relief of pressure, and then I noticed some drainage. That's a common clinical scenario that would make you think about them perforating that middle ear. Now, here's what's important. They can have otalgia, they can have a fever. What's really critical is not just the clinical symptoms, but the otoscopic findings. You can have a red tympanic membrane, but that's not enough for the diagnosis. The diagnosis really requires the presence of what we would support as an effusion, something that's pushing on the tympanic membrane. So what you really, really need is a bulging. You really want that bulging tympanic membrane. That's the key. You can have a red or erythematous tympanic membrane, but it's not needed for the diagnosis. It helps, but it is not needed. The critical finding is the bulging tympanic membrane. So oftentimes we will say that otitis media, acute otitis media, is a clinical diagnosis, meaning that the patient has symptoms, otalgia and fever, and then on top of that, on otoscopic exam, they have a bulging tympanic membrane. Doesn't matter if it's red, it's got to be bulging. And so sometimes we can do that with otoscopy, but sometimes you may not see it. And if you can't see it, we have to kind of maneuver and do some other tests. And we'll talk about that in the diagnostic approach, but we may talk about something like pneumatic otoscopy or tympanometry, which gives you a little bit more, one's a little bit more subjective and the other one's a little bit completely objective identification if there is a bulging tympanic membrane. All that bulging tells me is that there's an effusion present. All right, my friends, that covers this part here, but I gotta lead you to the next concept. Oftentimes, acute otitis media will present like this. Pain, fever, they'll have a bulging or red tympanic membrane or both, but you need at least the bulging. They may have otorrhea if they perf the tympanic membrane. But the key thing here is what otitis media can actually lead to. It's much more dangerous than malignant otitis externa. That can lead to malignant otitis externa in certain clinical scenarios. Complicated acute otitis media can lead to a lot of other things. This infection, it can spread to a lot of places. So what we get worried about is, can this thing spread to the mastoid? So you see here, there's these little like holes where it can kind of take the infection and it can move into this. And then imagine it kind of like moving behind and then infecting this. That's called mastoiditis. So that's one thing that we get worried about, is complicated acute otitis media can be leading to something called mastoiditis. Another thing is the infection can spread right over here via the round window into the inner ear. And when it does that, that's called labyrinthitis. All right, so we'll call that labyrinthitis. And then lastly, all right, not lastly, If the infection actually gets terrible enough, sometimes what can happen is it can spread into the actual meninges and in the brain. So that's what we get worried about, is this thing spreading up into the meninges or spreading up into the brain. And we can call that a CNS infection. So that's another one that we get worried about. And then another scenario is if the infection gets bad enough, we already kind of talked about this, but if it gets bad enough that it's pushing on the tympanic membrane so hard that it creates a little hole. Let's draw like a little hole here in the tympanic membrane. Then you can get a perforation, and you can get this fluid to leak out here, and that's where you get that otorrhea, right, that we talked about. So that's called a tympanic membrane perforation. And the last thing I will talk to you guys about here is a cholesteatoma. And that's basically, it kind of goes back to that concept that I told you guys, that whenever you have the middle ear pressure initially, it gets negative and it sucks, it pulls the tympanic membrane in, it retracts it. That can create what's called a retraction pocket. And that retraction pocket over time can get filled with like a lot of squamous cell and keratin debris, and it can cause this little nasty keratin debris to spread throughout the middle ear, destroy the ossicles, get into the mastoid sinuses and cause mastoiditis. And that's called a cholesteatoma. That's called a cholesteatoma. Now, one other thing that you can also see is called cranial nerve 7 palsy. It actually does run through the posterior wall of the middle ear, and then it kind of comes down and comes out around the stylomastoid foramen. So I would also always consider the possibility, it's just as not common as its own due to acute otitis media. You usually see it more as a result of mastoiditis, or you see it with malignant otitis externa. But every now and then, if you get a really bad enough infection of acute otitis media, that pressure and effusion may cause cranial nerve 7 palsy. And so you'll see ipsilateral. So if they have a right ear infection, they'll have ipsilateral, right-sided facial weakness. And it includes the whole side. The upper part, even the forehead is included. And that's really critical to remember. All right. This gives you a big justification of what we're talking about with acute otitis media. What I now need us to do is move into the next scenario, which is, okay, a patient has otitis externa, and they don't only present with otalgia and otorrhea. Now they got some weird kind of manifestations that are really, really scary. Or they have acute otitis media and they're not presenting with just otalgia and fever. They're presenting with some scary complications. Let's talk about those. All right, my friends, a little bit of a blank canvas here. May look a little bit different. Like, Zach, what the heck? Am I watching a new video? No, you're watching the same video. We just had a little editing error. We have to come fix this part here, finish this off, and then we'll get back to the original whiteboard. So it's just gonna have like a little, back and forth. All right, but it'll be cool. So we were talking about complications of otitis externa. I'd say one of the most common features is probably going to be hearing loss. Think about it. You have a lot of swelling here. So if you have this big old angry, swollen external acoustic meatus, this thing is all kinds of angry, and it's erythematous. And as that happens, I mean, think about it. You ever looked in like a really, really swollen child's ear? If they end up having otitis externa, sometimes you can't even see anything in there. The whole thing is kind of plugged off. And obviously that's because there's probably a significant amount of edema here, right? From the inflammatory reaction, bringing inflammatory cells in, bringing all the different types of increased capillary permeability, causing the vasodilation of the capillaries in this area. So that's going to be the edema factor, right? This is going to be all swollen, but it's also going to be really, really angry. There's going to be a lot of tissue damage from the bacteria, right? And usually that's going to be things like Pseudomonas. That's going to be the most common offender here. So we got a really, really angry and swollen external acoustic meatus. Now, the reason why that's a problem is air is basically, or sound is going to move, right? What? Via the external acoustic meatus. And as it tries to get through here, it's going to be like, ee, and it's barely going to be able to squeeze through this dang thing. Because of that, if you have a reduction going through at that point, at this point here where there's all of this narrowing, what's going to happen? Well, you're supposed to have the tympanic membrane vibrate and move back and forth, compress and decompress. And what that does is it causes movement in the ossicles. And so what happens is if air isn't kind of getting to this point, you're not going to get this back and forth of the tympanic membrane. I'm going to represent it like kind of like ringing. You're not going to get the vibration of these ossicles. You're not going to get the vibration of stapes. And if that happens, what's going to happen? It's not going to tap on the oval window as well. If it doesn't tap on the oval window, that's not going to produce the fluid-filled vibrations that occur within the cochlea. And if that's the case, it's not going to send those signals down the vestibulocochlear nerve. And eventually this will go to the brainstem. So what's happening here is you're stopping it pretty dang early. And where? You're stopping it here. So everything at this point is all being reduced. And so you're getting reduced signals that are actually moving towards the brainstem. And that's what we're having here, is we're having a person having some type of issue with that process. Now, when we think about this, what would this actually precipitate? Well, one of the things is that the person would actually not be able to hear things very well. But sometimes we want to be able to know, especially in children, is that a sensory neural deafness? In other words, is there something going on with like the vestibulocochlear nerve potentially? Or is it something in the external acoustic meatus, which is, here's where the problem is. Is it the ossicles? Is it the tympanic membrane? Is it some part of the inner ear or the cochlea? That's what we want to try to be able to figure out. And so we do something called the Weber and Rene test. And for simplicity's sake, what I want you guys to know here is that the Weber, and I'm going to explain what this means. There's going to be two components here. The Weber test will show lateralization of these actual sound, which we're going to talk about with a tuning fork. It has lateralization to the good ear. Actually, sorry, I apologize, to the bad ear. And I'll explain why. It has lateralization to the bad ear. And the Rene test is a negative test. And all that means is that usually in normal individuals, when you take a tuning fork and put it up against their ear, they should be able to hear the air conduction better than they do the bone conduction. But in these individuals who have conductive deafness, it's actually the opposite. And so what we mean by this is that their bone conduction is greater than the air conduction. I'll explain what I mean by that. All right, so they have conductive deafness. Why? Because of the swollen external acoustic meatus. Signals aren't actually, air sound is not moving through this external acoustic meatus as well. It's not causing the vibrations, right? It's not causing this nice movement of the tympanic membrane. It's not allowing the vibration of the ossicles. It's not tapping on the oval window. It's not leading to these nice kind of fluid-filled vibrations within the endolymph of the cochlea, and it's leading to decreased signals via the vestibulocochlear nerve to the brainstem, and that's what leads to the decreased sound. So what we do is the Weber test is you take your tuning fork, smack it, put it on the top of the head. And what you want them to tell you is, where do you hear that sound the most? And generally what happens is, let's say here is where the problem is all of the issue is on this right ear. They have some swelling here of their external acoustic meatus. Well, what happens is this external acoustic meatus is kind of in a way blocking out sound from the environment from coming in. And because of that, it's blocking all of this out. What's going to happen is if I take a tuning fork and I place it on this bone, it's going to cause vibrations within the bone. And that's actually going to cause the conduction to move to which side more? Well, if there's less action potentials that are going to this actual inner ear from the air, most of them are going to be more amplified here on this side. And so you're going to get more of an amplified effect. You're going to hear more of the actual bone conduction effect, or that tuning fork there, on the actual affected ear. All right? Rene test. What you do is you take the tuning fork, you tap it, and then from here you place it on like the mastoid process. And you have them kind of tell you if they can, hear it. And then at some point after that, you're going to move it over in front of their ear so that they can actually hear it as well. And what you're trying to compare is like basically the time and the sound, the duration essentially, and if they can hear it from here and if they can hear it from here. Now again, think about this. Because the external acoustic meatus is really swollen, it's the same kind of concept here. You should be able to hear it better normally when it's actually right here, and less effectively right here. But in these individuals, think about it. I'm going to represent with a dotted line. Less of this is getting to the inner ear. Most of it is getting from this direction. And because of that, the bone conduction is going to be much more effective than the air conduction for the Rene test. So again, otitis externa, what I really want you guys to remember is hearing loss is a pretty common complication. It'll go away as the actual infection clears and this edema reduces. But the primary mechanism behind that is that it's basically just obstructing the conduction of sound through its normal pathway. And the way that we determine if it's sensory neural versus, again, conductive, is we do the Weber and Rene test. if the actual bone conduction, whenever you put this on top of their head, lateralizes to the affected ear, it tells me that something is happening where it's actually sifting through, and it's actually not sifting through the air conduction as well. Renee tests, normal individuals, air conduction should be more effective than bone conduction. But in these individuals, they have an obstruction. And so they're going to amplify that sound, that bone conduction effect in this individual. All right, so the next thing is malignant otitis externa. This one is less common, but I think it's important to remember in the appropriate scenarios. So the people who we think about with malignant otitis externa is usually going to be individuals who have one of two particular risk factors. And I'd say uncontrolled diabetes is probably going to be one of the biggest ones, especially if they have like diabetic ketoacidosis. The other one is immunocompromised patients. So any type of immunosuppressed patient of any sort is at higher risk for this type of condition. Now, the thought process behind the diabetes is probably due to like microvascular ischemia and just disease, and so they probably have poor wound healing. The hyperglycemia definitely makes things a little bit more difficult in that regard. And then the immunosuppressed patients, they probably just don't have the proper immune response to fight off particular pathogens. But the big thing that I want you to know about with this condition is that there's a primary pathogen. Again, we talked about it before, and it's Pseudomonas. So Pseudomonas is going to be the primary pathogen that is going to cause this type of disease. Now, the thing about Pseudomonas is, again, in a normal immunocompetent individual, no underlying comorbidities like diabetes, you should be able to fight this thing off. It'll cause something like what? Well, it'll cause it'll cause generally like otitis externa. And so you'll get some inflammation of the external acoustic meatus, that kind of skin. All right, the epidermal tissue will get a little inflamed, you get a little bit of edema. But the big thing here is that this pathogen, if normally not contained, it has a little gateway to get into the bone. You see these little spaces here between the blue? These little spaces are called the fissures of Santorini. That's such an interesting name. It sounds like something where you go like, on vacation. I'm going to the fissures of Santorini, but it's an interesting one to say the least. But the fissures of Santorini is kind of like it's a gateway, essentially. And what I want you guys to know, Santorini, yep, there we go. The fissures of Santorini is basically a little gateway for the pathogens to be able to move their way into the bone tissue. And so if they can get into the bone tissue, they can actually start wreaking havoc, man, and causing a lot of damage to the bone. Well, like what? Well, let's say that the bacteria gets into the bone. So we'll represent a couple bacteria here in the bone. Well, now what can it do? Well, here it's going to cause tissue damage, and it's going to cause inflammation and infection of the bone tissue. What's that called when you have infection and inflammation of the bone tissue, especially kind of really deep within the bone tissue? That's called osteomyelitis, isn't it? That's essentially what malignant otitis externa is essentially this pathogen. Which one here? This is Pseudomonas aeruginosa. So Pseudomonas. Pseudomonas gains the ability in these types of conditions. In normal immunocompetent individuals, no comorbidities, this wouldn't be able to pass those fissures of Santorini. And if it did, you get demolished by immune system cells. But if it crosses over, it leads to osteomyelitis. And that's what's pretty kind of detrimental to this condition, is it can lead to osteomyelitis. The problem with this is the osteomyelitis is of specific kind of like bones. And so this is going to be a lot of the skull base, the mastoid process. And so you'll see this of like the skull base. You might even get things like the TMJ, the temporomandibular joint, and even the mastoid process, right? And so that's the real kind of issue here, is that this can cause a lot of detrimental effects. And so one of the biggest things here is when you get something like osteomyelitis, what's probably the most common types of symptoms that you would have from something like that? Pretty significant pain, dude. And so the common clinical manifestations from the osteomyelitis is usually going to be things like very, very severe ear pain. Oftentimes it's worse at night though. So ear pain is probably going to be a common one. Normally patients who have otitis externa shouldn't have fevers, but because this is starting to invade the bone, they're going to start getting things like fevers, So they'll have otalgia, they'll have fever. The other thing is that you're probably gonna have another potential problem here. And that's because you see this nerve here? This is your facial nerve. So this is called cranial nerve 7, also known as your facial nerve. It kind of runs through, it actually comes through the internal acoustic meatus, and then it kind of wraps in the back part of the middle ear, and then it moves through the mastoid bone. And so whenever a patient gets malignant otitis externa, it's very common for them to get a facial nerve palsy. And so that's another thing I'd watch out for, is if it does happen to occur here in this bone and be an edema that's compressing the nerve, or if it's directly kind of infecting the nerve itself, that's going to cause a facial nerve palsy. And so I would watch for something like a seventh nerve palsy. So a cranial nerve 7 palsy is also a pretty common clinical manifestation. So again, this patient's going to have some pretty significant ear pain. It's most often pretty significant. Nocturnal is another common one. They can have cranial nerve 7 palsy. The other thing I would watch is because this bacteria is really damaging the tissue in here, it tries its best to heal, but it does lay down a very, very thick granulation tissue. It seems to be somewhat pathognomonic for malignant otitis externa, so watch out for the presence of granulation tissue on otoscopy. All right, so the big thing here that I want you to know is in malignant otitis externa, it's really not going to be a super common one unless the patient has diabetes and they're immunocompromised of some sort. They'll probably come in with what seems like an ear infection, a lot of ear pain. They may even have otorrhea. There may be possibility of otorrhea as well. But the pain is going to be really, really bad, oftentimes at night. There's going to be fever. Sometimes the pain can even extend over to the skull base because of the osteomyelitis. And so they may have pain at the skull base. You're going to see facial nerve palsies potentially. That's a really concerning one. If you look in their ear, you'll see a lot of edema, but you'll see a lot of areas of dead tissue and debris called granulation tissue. But again, I think that's the real key thing here. But one other concept is just imagine, here's where it is. I just want you guys to get an appreciation of this. Here's where the infection is. It's here. But they have those gateways. What are those gateways? The fissures of Santorini. And in those scenarios, look where it can travel, dude. It can travel back here, right, to the skull base. It can travel here to the TMJ, right? It can travel all over the dang place. It can travel to the mastoid process. You guys get the point. And so what I want you guys to know is that this can really cause a significant amount of problems. And sometimes if it gets near the skull base, it could even start affecting like things like your jugular foramen, which you have a lot of vessels in that. You can even affect other cranial nerves as well. And so really, really important to understand that concept here is the capability of this infection is to spread to the bone. And that's what makes this one so detrimental. All right, well that covers this part here on otitis externa. Let's move on to the complications of acute otitis media. I'll see you back at the original board. All right, so let's move on to the complications of acute otitis media. So when we talk about this one, same thing, you can get hearing loss. When you have acute otitis media, it's pretty straightforward to think about the reasons why. But what I want to do is I want to talk about something. So with acute otitis media, that in itself, right, can cause conductive deafness. The reason why is it can cause two things. One is reduced, it's a decreased mobility. Let's go with that, decreased mobility of tympanic membrane, and also just the effusion. That fluid in the middle ear is also going to kind of create this environment where it's going to kind of cause this problem. I mean, you think about this. If you have some fluid, all of this effusion, that's going to make it harder for the sound waves to be able to move through the middle ear and then actually allow for that stapes to tap onto the oval window, right? The other thing is if you have all of this fluid and it's pushing on the tympanic membrane, it's bulging it outwards, which then whenever it needs to compress and decompress, it doesn't really move much. That's less vibration in the ossicles, less tapping on the oval window. Less tapping on the oval window leads to less fluid fill vibrations in the inner ear, and less action potentials being carried down the vestibulocochlear nerve to the auditory center in the brain. And so because of that, you'll perceive the sounds as being less. Now here's the thing. Acute otitis media can lead to these events, but also here's one other thing I need you to remember. Acute otitis media can also lead to a couple other issues, which is important. So acute otitis media can also lead to something called a cholesteatoma. So it can lead to a cholesteatoma. It can lead to a tympanic membrane perforation. And it also can lead to what's called labyrinthitis. Now, in these scenarios, because acute otitis media can trigger these three events, that also can cause deafness. And here's what I want you to remember. So this is how itself causes a conductive deafness. But acute otitis media can cause a cholesteatoma, a tympanic membrane perforation, and labyrinthitis. With a cholesteatoma, this is going to cause conductive deafness. Tympanic membrane perforation, you're not going to have mobility of the tympanic membrane. And cholesteatoma, it affects the ossicles, less movement of the ossicles. Labyrinthitis is an inner ear problem. So these here, we'll talk about this as an overarching theme here, is that acute otitis media can cause conductive deafness via this mechanism, and it can also cause conductive deafness via these complications. But with labyrinthitis, that's causing sensory neural deafness, which you want to remember, and we'll talk about that a little bit later. All right? So with that being said, again, we got to go back to our testing, the Weber and Rene test. With this scenario, it's the same exact dang thing. The Weber, you're affecting it because you have something obstructing the air conduction. So because of that, what will happen? This will cause the sound to lateralize to which ear? To the affected or to the bad ear. Because again, we have a reduction in that air conduction, which then allows for most of that kind of movement, most of that sound that's interpreted to be carried via the bone. So again, that's going to be to the bad ear. So you're going to have that concept. The Rene test is going to be a negative Rene test. And the reason why is because you have an obstruction of some sort or decreased mobility of the tympanic membrane that's reducing the air conduction. So now you're going to be depending upon the bone conduction. And so with this one, we have a negative Rene test, or we say bone conduction is greater than air conduction, which is not normal. All right? So again, in this scenario, what you're thinking about here is that you have air moving in to hit the tympanic membrane, you have bone conduction moving to hit the inner ear. What's being affected in these conditions is you're having a problem with air conduction. And as a result, most of the information is moving via bone conduction. And that's what's happening in conductive deafness. That's what's really, really critical to remember. All right, that's the hearing loss. So what I want you to take away from acute otitis media, its complications, and acute otitis externa is all of them can cause conductive deafness. Weber, lateralization to the bad ear, because what are we depending upon now? Bone conduction. Any conductive deafness, bone conduction is going to be amplified. Same thing with the Rene test, bone conduction is going to be more amplified than air conduction. Let's now talk about another complication. This is a really nasty one. A nasty one of acute otitis media is mastoiditis. If you get an infection of the middle ear, what can happen is it can spread via these like little holes, so like little antrum, that can move into, let's say it kind of moves backwards and comes right into this area. Here's the mastoid, right? So here's going to be the mastoid sinus. So here's the mastoid sinus. And you have a bunch of like air cells. All of these little pockets are air cells. What happens is the infection spreads and it gets into the mastoid sinus and it starts causing some nasty problems. So this infection gets here, and what it starts doing is it starts kind of breaking these bony septa between the air cells. When I break the bony septa of the air cells, I create this big coalescent mastoid cavity. And all that happens is this thing gets filled with pus. It's filled with a bunch of pus material. So that's what happens, is what I want you to remember here is, in this patient, they have acute otitis media. So they have acute otitis media. It spreads where? To the mastoid sinus. And then what happens is the infection destroys the air cells. And then you have one coalescent cavity filled with pus. We'll put purulent material. Now, with that being said, that is how a person gets mastoiditis. Is they have acute otitis media, that infection moves into the mastoid sinus, that infection, as it kind of moves here, starts breaking down more of the air cells. As you break down the air cells, it becomes one big cavity filled with pus. And here's the thing, you think, oh, well, if that's the case, can't it just drain back into the middle ear? No, it becomes so clogged up that now all of this starts kind of becoming enlarged. And as it becomes enlarged and more inflamed, it becomes very visibly evident when you're actually examining the patient. And so now what happens is the mastoid process becomes really enlarged and swollen and tender. And so what becomes the primary clinical manifestation is we say that they have a mastoid process, edema, and swelling. And it's so much swelling that what it does is it pushes the ear outward and forward. And that's really, really a key clinical differentiation here, is once you start having this patient who had acute otitis media and all of a sudden they got this big old goober in the back that when you press, it's like, ah, or it's swollen, it's red, and it's so swollen that it actually starts to push the ear outward and forward. That's when you start being concerned for mastoiditis. Now, one of the big things with mastoiditis is that yes, they're going to have all of the same kind of clinical pictures. They're going to have otalgia, right? They're going to have a lot of that deep ear pain. They're going to have fever. But one of the other clinical manifestations that's really, really critical here is they have that mastoid process, or that post-auricular tenderness and swelling and erythema. And that's going to push the ear outward and forward. So you're going to see all the same clinical features of acute otitis media: otalgia, fever, and then what else? The mastoid process swelling. What you get really concerned about here is look what runs through this kind of like anterior to the mastoid sinus and in the posterior wall of the middle ear. There's this nerve. What's this nerve here? And I kind of annotate this one here. This nerve is called cranial nerve 7. And as you can see, cranial nerve 7 runs through the posterior wall, kind of comes down and then pops out here. This can easily get damaged. And because of that, what's another clinical manifestation that you have to worry about? A 7th nerve palsy. So one of the things that we also get kind of concerned about is a cranial nerve 7 palsy. So these are the things I want you to think about with mastoiditis: is otalgia, fever, potentially a 7th nerve palsy, but the biggest thing is the swelling and tenderness and erythema of the mastoid process, that it pushes the ear outward and forward. Because of how nasty this thing can get, it can sometimes form abscesses. And so sometimes we actually do have to scan these patients to see, does it become a fluctuant? So that's one thing I would actually also say. If you tap on that and it's really mushy, like it's like a water bed and it's fluctuant, that would be concerning that it now became an abscess. And you actually might have to go and actually drain that and do some surgical intervention. So that's really, really critical, because that can also occur in this condition. All right, cool. Mastoiditis, we got that one. Really, really important you remember this one. Cholesteatoma is another complication. How this happens is actually really interesting. So when a patient gets, you have to remember, effusions, like having Eustachian tube dysfunction, puts you at risk of developing otitis media with an effusion. These effusions can then become infected and cause acute otitis media. But what happens is, usually in patients who get recurrent acute otitis media, they develop these scenarios where they create retraction of the tympanic membrane. Now you guys remember what I told you that happens is, when you start having this retraction of the tympanic membrane, it can create a little pocket, if you will. So imagine here that this is a person. We start off here. They start off and they have, we're going to say this is a patient who has recurrent acute otitis media, and they develop a retraction pocket. Because remember, whenever you get the inflammation of the Eustachian tube, it creates a negative pressure in the middle ear, which sucks the tympanic membrane inward, right? I told you that it kind of creates a little retraction. That retraction event allows for debris, cellular debris, squamous cells, keratin to build up in that retraction pocket. So then you get this keratin debris that gets in there. So here's the retraction pocket that we formed. And then let's represent the debris with this orange color. So here, some of the squamous cell debris starts kind of getting in there. What happens is that eventually this pocket starts to erode into the middle ear cavity. This thing literally, I'm not even kidding, watch this. It starts to erode its way in to the middle ear cavity. So it kind of breaks through the tympanic membrane. And it's usually at the pars flaccida, the top part of the tympanic membrane. And then you get this like nasty kind of area here where it broke through. And now all of this keratin debris is sitting in this middle ear. And then what it starts to do is it can start to invade onto the bones. It can start causing destruction of the ossicles. And it can also move what's into that little antrum. That little antrum leads to the mastoid sinus. So this is what we see, is this nasty cholesteatoma, that what happens over time is that this cholesteatoma can lead to some nasty issues. So the cholesteatoma, which is this big keratin debris and squamous cell debris that keeps migrating inward into the middle ear, can destroy the ossicles. And it can also do what? Invade the mastoid sinus. And that's what puts you at risk for mastoiditis, and it also can destroy the ossicles. And if you destroy the ossicles, what can that do? That can lead to deafness. So this is why they get conductive deafness. If you invade the mastoid sinus, they can get mastoiditis because it can obstruct the mastoid sinus. And if you reduce that ventilation and drainage from the actual mastoid sinus, and that can lead to mastoiditis. So here's what I want you to remember. Cholesteatomas occur from patients who have chronic Eustachian tube dysfunction. That creates recurrent events of acute otitis media. That causes a retraction pocket. That retraction pocket gets filled with keratin debris. As it gets filled with keratin debris and it continues to invade into the middle ear, it becomes a cholesteatoma. The cholesteatoma can destroy ossicles and invade the mastoid sinus. And again, what can this lead to? Deafness. What can this lead to? Mastoiditis. Let's actually write this down. So this can lead to deafness. Which type? Conductive deafness. And this can lead to mastoiditis. The reason why this is so critical is that oftentimes we have to actually remove the cholesteatoma and we have to repair the ossicles, repair the tympanic membrane, and cut out the mastoid sinus. They do a mastoidectomy. That's why it's critical to know. Last thing is when we think about a cholesteatoma, they'll present maybe with deafness, maybe they'll present with symptoms of mastoiditis, right? They may even present because of all of this like nasty debris. Another thing that's also critical is that this stuff can really cause a nasty otorrhea. And so I would also look for the term a foul-smelling otorrhea. And that's because of all that squamous cell debris kind of getting trapped in that area of the middle ear. And that's going to be a really, really critical one. So watch out for the foul-smelling otorrhea. That's probably a telltale sign. You also want to watch out for this deafness, this conductive deafness. These are probably the two biggest ones. But to add on to that, whenever you have these types of presentations, you should take a look in the middle ear. Look at the actual ear. So you should do an otoscopic exam. What you'll notice is you'll notice the retraction pocket, and you'll notice this like brown mass that's near the top part of the tympanic membrane within that retraction pocket. And sometimes this thing is pretty nasty looking, all right? And so that's the key thing, is you're looking for a retraction pocket, and you're looking for this brown mass, which we're going to call the keratin debris. So two things you're going to want to notice. See if you can find a retraction pocket. And in that retraction pocket is going to sit some keratin debris. And usually that keratin debris is kind of like a brown, orangish appearing mass. So we'll say a brown mass. All right, that's the key things that I want you guys to be able to recognize. So look for the otoscopic exam findings, look for the foul-smelling otorrhea, and look for the deafness due to the destruction of those ossicles. That's a key thing. All right, so far, hearing loss, and we already talked about how cholesteatoma can cause this type of hearing loss. We got that down with conductive, we got mastoiditis, we got cholesteatoma. What else we got? We kind of talked about this one a little bit already, so it'll be a quick little reminder. But whenever a patient has acute otitis media, it's pretty straightforward. Think about this. You have this middle ear effusion, this infected fluid. It's building up pressure, dude. So because of that, you're having a high pressure, high middle ear pressure because of an acute otitis media, right? So you have a high middle ear pressure. And what happens is if that pressure builds up enough, it can cause a perforation in the tympanic membrane. Now, whenever you perforate that tympanic membrane, what's going to happen is you're going to create a little hole. So let's actually draw like a small little perforation here. There's going to be a little hole now that now allows for communication of the contents from the middle ear into the external ear. And so what you're going to notice is all of this infected fluid is going to ooze out. So what is going to be the common clinical manifestation? It's going to be otorrhea. Now, whenever a patient has otorrhea, you start thinking, could this be malignant otitis externa, otitis externa? You often don't think about acute otitis media unless they perfed. So what happens is usually on the exam, you'll have a patient who has otorrhea, and here's the classic clinical case. They're going to have otalgia prior because of this high middle ear pressure. So because of this high middle ear pressure, they're going to present with otalgia. And that otalgia, or that ear pain, they're going to have a perforation. That perforation in the tympanic membrane is going to cause a sudden relief of otalgia. And that sudden relief in combination with some otorrhea is really going to start making you think about a perforated tympanic membrane, right? So the presence of otorrhea with otalgia that then has a sudden relief of what they feel is pressure is really suggestive of a perf. So what you're going to want to do is take a look. And when you take a look, to your surprise, guess what you'll find? You'll find a perforated tympanic membrane. Now again, think about this. With a perforated tympanic membrane, what else would this patient potentially have? They may have some worse hearing, right? So they may have some conductive deafness. Again, that's common because, again, when you think about the perforation of the tympanic membrane, you're now affecting the vibrations of the tympanic membrane. You're affecting the vibration of the ossicles, the tapping on the oval window. But we know that acute otitis media, cholesteatoma, and a perfed tympanic membrane all can cause conductive deafness. What causes another type of deafness that could be a complication? Labyrinthitis. Here's what I want you to think about. Labyrinthitis, it is a potential complication of acute otitis media. It's not super common. There's two different types of inner ear infections. One is called vestibular neuritis. Now there is a difference. I actually want you to know this. This is not the same as vestibular neuritis. These are not the same thing, all right? Not the same thing. Vestibular neuritis is primarily inflammation, usually, of the vestibulocochlear nerve due to some type of a viral infection, usually. Labyrinthitis is inflammation of the inner ear structures, particularly the cochlea and the vestibule. That's the difference here. So let me explain something. In a patient who has labyrinthitis, you have acute otitis media. What happens is this infection, there's a little window here called the round window. That's where the stapes, kind of like you have the round window and the oval window, right? So sometimes this infection can spread through the round window, it can spread from the oval window, and it can cause an infection to now move right via these windows into the inner ear and the cochlear duct, or into the vestibule where the utricle and the saccule are. And because of that, guess what you can get out of this? You can get vestibular dysfunction. So now you're going to have vestibular dysfunction because you're going to damage the hair cells in the vestibule, which this controls a lot of your balance and your overall kind of equilibrium. Then it's also going to destroy the hair cells in the cochlear duct. So now you're going to get cochlear dysfunction. All right? So I got the cochlea all jacked up. With that being said, in this patient who has acute otitis media that then spread via the round window, the oval window, damaged the vestibular hair cells, the cochlear duct hair cells, these things get all jacked up, how would that clinically present? Well, vestibular dysfunction may present with vertigo, or it may present with nystagmus. So it may present with vertigo, or it may present with nystagmus. That's one potential thing that I want you guys to think about. The other thing is with the cochlear dysfunction, this may present in two particular ways. It may present with hearing loss, and here's where I want you guys to think about this. Hearing loss, and it can also present with tinnitus. So that ringing in the ears that you can sometimes hear. When we think about this, if a patient has acute otitis media, all of a sudden they develop a combination of vertigo or nystagmus plus tinnitus or hearing loss, you now have to be concerned that they have labyrinthitis, especially if it's an acute onset. That is the difference between these two. Whereas vestibular neuritis, it usually is only going to cause things like vertigo, things like nystagmus, and associated nausea and vomiting that they may have because of the vertigo. That's what I want you to remember. And one other thing here, that hearing loss. What kind of hearing loss are we talking about, bruh? We're talking about sensory neural. So let's write that down. This is sensory neural deafness. So this is going to be sensory neural deafness. And that's another thing that would help you to distinguish between these two. So if you did the Weber and the Rene test on this patient, what would you potentially show? The Weber would show lateralization of the bone conduction to the good ear, right? It's going to the good ear because now there's no obstruction. Air conduction is always going to beat bone conduction. But because there's no obstruction, those things get to the inner ear at the same time. It's just in this scenario, it won't really matter because again, in this scenario, the inner ear is going to respond no matter what. It's actually not going to respond no matter what because it's damaged. The Rene, again, same thing. Air conduction is always greater than bone conduction. So in this situation, it doesn't matter. So what you'll see with the sensory neural deafness here is you'll see that the Weber will show what? It'll go to the good ear. So lateralize to the good ear. That's an important thing to remember, all right? And then for the Rene, what will you notice? For the Rene, it'll be a positive Rene test. And what that means is that the air conduction will be greater than bone conduction. Essentially, I like to remember that it's essentially opposite of what the conductive deafness is. Now, this is because you're damaging the inner ear. Anything usually by the point of from the actual stapes going outwards is usually your conductive deafness. Anything from the inner ear going inwards to the actual brainstem going onwards, that's going to be your sensory neural deafness. All right? So with labyrinthitis, I want you to watch out for vestibular dysfunction, which can be manifested in the form of vertigo or nystagmus, and cochlear dysfunction, which can be manifested in the form of tinnitus or hearing loss. All right, so let's kind of go through now in a scenario. Let's say that a patient came in, they had acute otitis media, and then all of a sudden they developed vertigo, like an acute onset of vertigo. They developed maybe some nystagmus, they developed some hearing loss. Yes, that screams more of a labyrinthitis picture, but I think it's always important to remember, especially when we're talking about being clinicians, if a patient presents with an acute vestibular syndrome, so an acute onset of vertigo and nystagmus, it's important to always consider like a central lesion as a potential cause. And that's where sometimes something called a Hintz exam will come into play. And a Hintz exam is a simple kind of like physical exam that you can do to help with a certain degree of saying, I think it's unlikely to be a central lesion and they don't need imaging, and it supports more of a peripheral lesion. And so a peripheral lesion in this case would be something like, there's something wrong with the inner ear, there's something wrong with the vestibulocochlear nerve. There's nothing wrong in this scenario with the brainstem or with the higher control centers inside the brain. That's what's really important to differentiate. So we do this, the Hintz exam is a head impulse, that's the HI, the nystagmus, and the test of skew. So that's where we get the Hintz exam. What you do is, with the head impulse, you just kind of have them keep their eyes fixated on your nose, and then you quickly turn their head. Normal vestibulo-ocular reflex should be that your eyes, if you have them look at you and you kind of have them turn their head quickly, they should be able to stay fixated on your nose. They shouldn't have something called a corrective saccade. So a corrective saccade means that if you had them kind of like, you wanted them to fixate on your nose and you kept turning their head to the right, and they went in that direction and then they beat backwards. You see how that kind of happens? You turn their head to the right and then they beat backwards, or you turn their head to the left and they beat backwards. That corrective saccade tells me that there's an abnormality in the vestibulo-ocular reflex. There's something going on maybe in the inner ear or the vestibulocochlear nerve. So if I have them turn to the right and keep fixated on my nose, then what should happen is this would be the normal response. You have them turn their head to the right, but they are able to fixate. This is a normal response. All right, so that tells me that there's a normal kind of vestibulo-ocular reflex. This right here, where they keep going and then they have a corrective saccade afterwards, that corrective saccade is what's concerning. All right, and that is abnormal. All right. The next thing is I want to know nystagmus. Now, nystagmus is kind of like a beating of the eyes. So you can have nystagmus, and what we kind of we're considering here is if what I'm trying to do is to determine if there's a central or peripheral lesion. If they have a normal head impulse test, that kind of concerns you more potentially for a central lesion. If they have a corrective saccade from the head impulse test, this suggests more of a peripheral lesion, something like labyrinthitis. For nystagmus, what you want to know is that an essential kind of lesion versus a peripheral lesion, so peripheral lesions, more like labyrinthitis, this will have usually a gaze beating nystagmus. So a gaze beating nystagmus. All right? And so that means if you have them look to the right, they're going to have that right beating nystagmus. So that's one thing that would kind of make me concerned more for a peripheral lesion. If I think about a central lesion, a central can have, what really I think differentiates it is that usually peripheral won't have any kind of vertical nystagmus or torsional nystagmus. And that's really the big kind of thing here, but it can have a unidirectional nystagmus. And so that's what's really the key thing here is that it can have a vertical nystagmus and a torsional. And that's really what more I'd say likely screams a central lesion, is a vertical or torsional nystagmus. So again, peripheral lesions, think about a gaze beating nystagmus. For a central lesion, think about a vertical or torsional nystagmus. For a central lesion, they should have a normal head impulse test. For a peripheral lesion, they should have a corrective saccade. And then lastly is the test of skew. What you do is you take your hand over the eye, and then you look to see if their eye deviates, and usually it will deviate vertically. If it deviates vertically, that's a central lesion. So if you have a vertical gaze deviation, that is a central lesion. So that should concern you for a central lesion. If there is a gaze deviation, and if there is not a skew deviation. So in this scenario, let's say that we kind of represent this with positive and negative. So if there is a deviation or a skew, whenever you cover their eye, that's a central lesion. If there is not any deviation with covering their eye, that is a peripheral lesion. So what you look for is you want to have a person have all three to have a peripheral, to support more of a peripheral lesion like labyrinthitis. So if a patient came in with an acute onset of vertigo, nystagmus, I did the head impulse and it showed a corrective saccade. They have a gaze beating nystagmus without vertical or torsional nystagmus. And their test of skew shows no skew deviation when you cover their eye. That supports a peripheral lesion. If you have one of these that are positive, you then need to be concerned that it's a central lesion. You need to get imaging. All right, that's the key difference here. So that's a quick little rundown on what I want you guys to remember is in a patient who presents with an acute onset of vertigo, nystagmus, you really want to differentiate if it's a peripheral or a central vertigo. And you can do that with the HINTS exam. You need all three of them to support a peripheral lesion though. You only need one of these to support a central lesion. That's critical. If you have one, you get imaging. The last thing I want to talk about is the complications of acute otitis media CNS infections. This is a sad one because what happens is when you think about these infections like acute otitis media, if you have this infection, it's occurring here in the middle ear, what happens is you have a small little bone here called the tegmen tympani, so the roof. And this infection can easily spread via the tegmen tympani to the brain or to the meninges. And so because of that, you can get an infection of the meninges. And when you get an infection of the meninges, what is that called? Meningitis. If you get an infection that starts off with like cerebritis, and that cerebritis becomes like, you start having necrosis of that tissue in the center, and then you encapsulate it, and you get this walled off infection. What do we call this? A brain abscess, right? So I think the two biggest things that you want to remember here is you run the risk of something called meningitis and you run the risk of a brain abscess. Other things can happen like empyemas. You can get like an epidural empyema. You can get a subdural empyema. And those are also something to consider, but a brain abscess is definitely one to think about, and meningitis is definitely one to think about. Now, what would be the clinical concerning symptoms? What would be some red flag signs here? Some red flag signs that make me really, really concerned that the patient could have some type of intracranial extension is if they present with a very, very high fever, so high fever, headache, some type of meningeal sign, or a cortical sign. And I'll explain what I mean by that. So a headache is we have some type of dural irritation. We have some type of process here where you're causing irritation of the dura, right? Another one is fever, and usually this is a pretty high fever, especially in meningitis. And then the next one is we talk about meningeal signs. So the meningeal signs are your nuchal rigidity, your Brzezinski's, your Koenigs, right? That would support more of the meningitis picture potentially, right? And even the jolt accentuation maneuver. And this would push you to go ahead and get like something like a, what? Maybe like a lumbar puncture. And then the other one is the cortical signs. And the cortical signs, what that means is maybe if this is in the temporal lobe, which is common with otitis media, you can get things like aphasia, seizures, contralateral hemiparesis. So these are things to definitely consider as well. So watch out for any kind of cortical signs like aphasia, like weakness, like seizures, like cognitive or behavioral changes, which are also something to consider as well. But this really makes me concerned about a CNS infection. Woo-wee! We talked a lot about ear infections and really how they occur, what they can present like, what the most common pathogen is, and what could happen if you don't treat these properly or recognize how severely they can spread and cause a ton and plethora of complications. So it's really critical to be able to identify these. And so let's now take the time to say, how can I systematically, in a way, without going through all of this, because I'm a clinician, I ain't got time for all this all the time, how can I systematically evaluate a patient to come up with the diagnosis, the associated complications, and treat it? Zach, get me to the, I need a little bit quicker. Let's get there. Let's talk about that now. All right, my friends, let's now move on to the diagnostic approach to ear infection. So what's the most common kind of chief complaint probably with across the board with otitis media and acute otitis externa? It's probably going to just be ear pain. So it's probably going to be otalgia, right? So that's the first thing. But I think that what comes along with otalgia is before you start really kind of like, thinking about like, all right, is it malignant otitis externa? Or I'm sorry, is it otitis externa? Is it otitis media? Is there complications? The first thing that I like to always kind of look through in the vignette or when I'm doing a history is, are there any red flag signs that are associated with this? Because what this would tell me is it would tell me about things like malignant otitis externa. What would that look like? Well, their otalgia would be like really, really bad. And on top of that, they probably have somewhere in their history that they're uncontrolled diabetic. Maybe they have an immunocompromised condition of some sort, or they're on an immunocompromised regimen. That would make me think about malignant otitis externa potentially. Another one is they got cranial nerve deficit. So if I have otalgia with a cranial nerve deficit, especially since the cranial nerve 7, facial nerve, runs through the middle ear, especially within that facial canal, that's a very prominent area that if the infection is really extensive, it's spreading through the bone, it's spreading into other areas like the mastoid, it's spreading towards the skull base near where the stylomastoid foramen is, you can definitely get a cranial nerve 7 palsy. So watching out for kind of like a unilateral, one-sided like facial weakness, right? Including the forehead. That's a really important one. Post-auricular swelling, tenderness, maybe it's a fluctuant kind of like mass. That would really concern me about a mastoiditis picture, and they would have a pretty bad fever as well. Headache, fever, meningeal signs. They have neck stiffness. They have that nuchal rigidity, right? They have the Koenigs, Brzezinski's, the jolt accentuation maneuver, or cortical signs. So altered mentation, maybe they have seizures, maybe they have some type of aphasia, maybe they have a hemiparesis. All of those things would concern me about a CNS infection potentially. And then if they have the acute onset vertigo with nystagmus and maybe hearing loss, it would concern me more instead of an acute vestibular neuritis. It would concern me more particularly for a bacterial labyrinthitis. And so these are things that makes me kind of like say, ooh, this is a patient who probably does have one of these things that I was talking about. But my worry is that it got complicated. So they had an acute otitis media and an otitis externa that then aggressively got worse. And then my decision from there is going to say, okay, I'll still go through my steps that I'll probably go over here on the left, but I'm probably going to need some imaging of some sorts. So that's what I want you guys to think about. All right. So it may push you for imaging because acute otitis media, acute otitis externa, those are usually clinical diagnoses. So let's kind of say that in this patient that you don't have any red flag signs. You got time then to say, okay, let me really start thinking about, okay, is this acute otitis media or otitis externa? So what I want you to do is inspect the ear, inspect the external ear, inspect the ear canal, look at the tympanic membrane via otoscopy. When you do that, what you're going to find is a lot of genuine helpful information. One is if I pull on the pinna or I push on the tragus and it's extremely painful, that really makes me think about an otitis externa. And on top of that, if I also see some swelling there, and on top of that, their external acoustic meatus is really swollen, maybe it's red, maybe there's some otorrhea there. But the big thing is the TM, either if I want to see it, that's really, really important. We want it to be intact. Now, sometimes there's so much swelling that you won't even be able to see the tympanic membrane. But the biggest thing is that when you look at the ear and you see that there's a lot of swelling and irritation, and when you look in the ear, you see how the external acoustic meatus has a lot of this purulent material. It's a lot of swelling. It's red, and it kind of can see the tympanic membrane, but not completely. We just want to make sure it's not perfed. The reason why is it kind of helps us in making decisions about treatment, and also helps us to make sure that this patient doesn't also potentially have an acute otitis media that is the source of their otorrhea. Okay? That's one thing to think about. Now, from here, the next thing is, what if I don't have pain with pulling of the pinna? What if I don't have pain with pushing of the tragus? In this patient, when I inspect there, I really want to look at this. When I look, if I see a normal tympanic membrane, what you're looking at is your basic landmarks, right? So you have this whole area here called the pars tensa. You have this one up here called the pars flaccida. You have the handle of the malleus. You have the short process of the malleus. And then you have this basic thing down here called the umbo. And you'll see this little area here called the cone of light, right? What's really, really important is you want to try to be able to visualize these things. But the biggest thing here is you want to say, is there bulging of the tympanic membrane? Is there redness of the tympanic membrane? Can I see fluid behind the tympanic membrane? But the most important is bulging. All right. So you want to be able to see that. So you see how this person has both bulging and it's pretty red. And over here, we can see bulging and definitely a lot of redness. This is really characteristic of an acute otitis media. So if they have the clinical symptoms and the otoscopic findings, boom, you have acute otitis media. Now, what about the patient who does have pain with pulling of the pinna, no pain with pulling the pinna, no pain with pushing the tragus? You do an otoscopy and it's just red, but it's not bulging. Can I make the diagnosis? No. So when this is not common, but especially I'd say more in the pediatric population, we would definitely go this next step. You want to see, is there fluid behind the middle ear? You want to know if there's an effusion, essentially. So what we would do is we have an alternative to go to the next step. We want to see, is the tympanic membrane moving? That's really the key thing. Because if it's not moving, that means that there's a really significant risk of an effusion there. And that's causing pressure to build up and it's not allowing the tympanic membrane to move. And that would help me with the diagnosis. But how do I do that? That's when we do something called pneumatic otoscopy or tympanometry. Pneumatic otoscopy is an easy one. It's a bedside one, but it involves a lot of objective kind of evidence and a lot of skill and also a proper patient who's going to work with you, right? Which is hard in the peds. But essentially what you're going to do is you're going to kind of use your otoscope. You're going to then push in some air. And when you push that air in, it should then push the tympanic membrane in. And then when you kind of release it, it should create a negative pressure and that tympanic membrane should kind of move back to its normal position. So you're looking for mobility. If there is no movement, that means that that's a concerning feature. That means that this is possibly an effusion behind the tympanic membrane in the middle ear. If there's normal mobility, all right, you're good. But again, this is more of an objective thing. And patients who are moving a lot, it's hard to see, you can't really tell. We go with tympanometry. This is definitely utilized, but I'd say it's more often utilized as a follow-up measure, and especially in effusions and acute otitis media. So what we would do is essentially it's kind of like occluding and it's sending a particular kind of like wave and it's giving you all kinds of information that basically it measures like the compliance essentially of the tympanic membrane. And it's going to give you kind of this graphical representation and tell you if there's normal mobility or not. So it's definitely a little bit more objective and easier in the patient who's kind of really, really moving a lot and you can't visualize while you're doing this. Either way, what I'm looking for is no mobility or normal mobility. All right. In this situation here, if we got a reduced mobility or no mobility, that's acute otitis media because you have the clinical symptoms, but you don't have all of the actual otoscopic findings. All right. So we want to know that they don't have, we want to know if they have any kind of reduced mobility. Essentially, we need to know if they have an effusion. All right. So if they have decreased or no mobility, there's an effusion present combined with the actual clinical symptoms, we make the diagnosis. If the mobility is completely normal, that's when we started thinking about, could this be something else? Right. So if we don't have an effusion present, what else could it be? All right. So that's really, really, really important to think about that. So bulging tympanic membrane, clinical symptoms, that really seals the diagnosis. If you have the clinical symptoms and redness, it's not enough. Confirm that there is decreased mobility with pneumatic otoscopy or tympanometry. All right. What if I have another patient that I look and I notice that there's a lot of drainage? And when I look on the otoscopic exam, I see this. There's a tympanic membrane perf. That's usually a complication of, in this scenario, maybe it could be of acute otitis media, it could be barotrauma, there's a lot of different reasons, but in this scenario here, that could be a potential complication of acute otitis media, all right? That's something I want you guys to think about here, especially if it was accompanied by otorrhea, because all you did was open up the opportunity for all that fluid and pus to leak out of the middle ear if there was a middle ear infection. Now, the other thing is if a patient has otorrhea, right? And it's maybe really foul smelling and malodorous, and then you look into the actual otoscope, and when you see it, you see a retraction kind of pocket filled with like this brown yellow debris, right? That could be a cholesteatoma. So you guys see how there is kind of like this area here. This is a nasty cholesteatoma. There's actually kind of a tympanic membrane perf here because it does erode through the tympanic membrane. But this right here is very, very characteristic of a cholesteatoma. We see this in patients with very, again, consistent, acute otitis media or effusions where you generate that negative pressure inside of the middle ear that kind of sucks the tympanic membrane, creates that little kind of retraction pocket. So it's pretty persistent and recurrent acute otitis media or effusions. All right, especially with chronic Eustachian tube dysfunction. Now, when you see this, you should get imaging because, again, it helps you to determine, at least in this scenario, the extent. So has it kind of extended into the mastoid sinus? Has it extended and caused a lot of destruction of the ossicles? And so here you can kind of compare, and what you'll notice is you'll see that there's kind of a pretty significant area here. That's a cholesteatoma there, you can appreciate. We can kind of zoom in on it, and again, you can compare here to this one. You'll see that there's kind of like this hypodense collection there. That's another cholesteatoma. And then here we can actually see how much that this thing is really eroded. So there's actually a bone here. There's supposed to be the incus, and it looks like that thing's just pretty much like eroded away. And so that's really important. And again, this is malleus, just so you can kind of see that one. But that's what I would want you guys to think about, is that when you have no red flag signs, the first thing that you want to think about is, how do they respond when I pull on the pinna? How do they respond when I push on the tragus? Do they have any drainage? Look in the ear. If you look in the ear, you see a normal TM, but you see a lot of swelling of the external acoustic meatus, otitis externa. You see a bulging tympanic membrane, acute otitis media. You got a red tympanic membrane, but you do pneumatic otoscopy, tympanometry, and it shows low mobility. You got acute otitis media. You got otorrhea, but you look in, there's a hole in the tympanic membrane. That otorrhea was probably from a middle ear infection that probably, again, perfed the tympanic membrane from high pressure and drained out. You got a cholesteatoma, could be recurrent acute otitis media, Eustachian tube dysfunction, persistent effusions that cause negative pressure, create a retraction pocket, and you get a cholesteatoma. And then you want to look at the CT scan to determine the extent, because that's going to guide surgical planning. All right. So if you got the red flag signs, all right, and we talked about these, what would that help you with? Well, I'm thinking about complications now. I'm thinking that I had an acute otitis media that spread. I'm thinking that they have an acute otitis externa that in the clinical scenario that fits, it became malignant otitis externa. That's the thing I want you guys to think about. So if I have these suspicions, what would it be? Just to go back and remind yourself. If I have severe otalgia and a diabetic and immunocompromised, I'm thinking about the patient who has a malignant otitis externa. Especially if they have a cranial nerve 7 palsy, they have extensive amount of pain, especially around the skull base. I'm definitely thinking about that one. If I got cranial nerve deficits, it definitely makes me think about malignant otitis externa or mastoiditis. If I got some kind of like post-auricular swelling and tenderness, definitely makes me think about mastoiditis. If I have any headache, fever, meningococcal signs, this is the worst case scenario. I'm worried that it extended into the central nervous system. And these scenarios, you can probably do pretty well with saying, let me get a CT scan. Let me look at the middle ear. Let me look at the sinuses. Let me look at the bones. Let me even get a part of the brain to even get a portion there. So I'd probably be doing a CT scan, really getting a view of the temporal bones, and really also looking again at the brain too, just to make sure that I'm kind of not missing if this has spread beyond the middle ear or even from the external ear. So when you do that, what you'll notice is a bunch of different things. For example, if I had this patient who I got a CT scan because they presented with some symptoms like I see some skull base osteomyelitis, that would really be scary. So you can see over here, this patient's got a lot of inflammation of their external acoustic meatus. And then over here, I can see that there's some bony erosions. That's pretty concerning. They probably got some skull base osteo, and this could be malignant otitis externa, right? So you can kind of see this one here. Kind of like a little bit of some air coming through here. Look how much swelling there is here. And you can see there's some bony erosions there. This is pretty consistent. So that's a pretty nasty one for a malignant otitis externa. All right. The next thing here is, I think once you kind of have a concern that this patient has malignant otitis externa, you'll notice a lot of granulation tissue also. So when you look on the otoscopic exam, you'll notice a lot of this granulation tissue. You should try and do a swab of that. I think that's a really, really important one because it helps to guide your antibiotic choice. The next thing that I want you guys to think about is if we did this and a patient has an opacified mastoid sinus, or they got a coalescent mastoid sinus. So for example, if I'm looking here, this is what a mastoid kind of sinus should look like. This is a really, really opacified. So this is a concern that the patient had maybe an acute otitis media, and this spread via the mastoid antrum into the mastoid air cells, and it started causing some infection here. So this is all like pus material. What can happen though is that can cause consistent destruction of the actual mastoid air cells to the point where the bone starts to get pretty much ripped away. And what you're left with is this big kind of like coalescent area. And that's a really nasty concern. But also another really bad concern here is we can see here is the mastoid sinus is really, really filled with purulent material. Look at this. You got a vein nearby, a cerebrovenous sinus that's getting kind of inflamed, and this can cause a thrombosis. So that's another really, really big concern here. All right. So this would really be concerning for, again, a extension of the infection into the mastoid sinus. And this would, again, help us to confirm the diagnosis, but also, again, may guide some of the management. All right. The next thing that I want you guys to think about is, again, in this patient who has that headache, that fever, those meningeal, the cortical signs, if you do this and you see, okay, they have a normal CT scan, maybe you consider meningitis and you do an LP. But if you look at it and you see something like this, you're like, oh my gosh, this infection extended into the brain and they got an abscess, right? So that's a pretty concerning one. And these usually you always have to get like an MRI to really fully confirm it. And so that's something that you would probably end up getting to see. Usually these are in the temporal lobe. Usually these are in the cerebellar lobe, just given the location of where they are. All right. But that's something that you would want to consider, again, as a possible complication. So the whole purpose of this is that you do not get CT scans routinely for patients who have acute otitis media, acute otitis externa, and technically you don't even have to get a CT scan of a patient with mastoiditis. I think getting a CT scan of for mastoiditis is also sometimes a little bit controversial, but I think it's helpful to know the extent of it. And also, again, it can help to guide a little bit more of the management. So again, that could be controversial, but at least for these, you're getting a CT scan to look for complications. All right. Now, let's also say that I have a patient here that I have a suspicion of labyrinthitis. What would that look like? Again, that's that acute onset of vertigo, nystagmus, maybe some hearing loss. That's really going to concern me that we've involved the vestibule, we've involved the cochlea, and that's when I want to start digging into that one. What would I do with this one? Well, the first thing you need to know is when a person presents with an acute onset of vertigo and nystagmus, you want to definitely consider the possibility of a central lesion that's causing this, like a stroke, a tumor, or is it a peripheral cause, like labyrinthitis? So what do? You do something called a Hintz exam. And a Hintz exam is basically you're going to go through and look to see if you do a head impulse. Whenever you do this, you want to know, do they look, and if they, basically you hold their head, you have them look directly at you. We talked about this on the whiteboard. And whenever you turn their head, you tell them to keep your eyes fixated on my nose. And when you do it, what you want to know is that they can keep their eyes fixated. If they look in the direction in which they're moving and then they correct backwards, that's a corrective saccade. And that really screams more of a peripheral cause. The other thing is that you want to look for a nystagmus. Is it really just in the direction that they're gazing in that they have a nystagmus? Or is it vertical? Is it torsional? Those are usually screaming more of a central cause, right? So if it's just purely horizontal in a direction gaze, that screams more of a labyrinthitis or peripheral lesion. And the last one is skew deviation. If you take your hand over their eye and you have them kind of just look at you, you'll notice that they have a deviation upwards. That screams more of a central lesion as compared to a peripheral. So again, recapping that. If I do that, I do the head impulse and it's abnormal because they have a corrective saccade, that screams peripheral. If they have a horizontal, that's usually in the gaze direction, nystagmus, that's going to be peripheral. And if they have no skew deviation, that is going to be suggesting a peripheral lesion. You're not going to need to get any imaging. And the patient who does have a head impulse test that's normal, so in other words, because you're testing their vestibulo-ocular reflex. If they do that and they're actually able to keep their eyes fixated on you, that could be a sign of a central lesion, right? And if they have Vertical, torsional nystagmus, that could be a sign of a central lesion. And again, vertical skew deviation, a central lesion. In those patients, you want to get imaging. So you want to actually do brain imaging to really kind of figure out what the heck is going on. All right. So any one of these are positive, you get imaging. If they're all negative, you can feel pretty good about a peripheral lesion. All right. Let's then move into the next component here, which is we've diagnosed everything. How do we treat? Well, an otitis externa, it's actually pretty straightforward. A lot of it's going to be pain control because it's extremely painful. NSAIDs, acetaminophen is going to be your go-to. Oral toileting, essentially, it's just maybe you'll kind of we'll kind of clean out. Sometimes you'll actually irrigate the ear and clean out any kind of purulent debris and material. So that's one potential consideration. And it's also just, again, getting all that debris out, removing as much as you can so that you can get the medication into where it needs to go. I've actually seen sometimes they're so swollen and edematous that you can't even get the ear medication to move into the area of injury because of how much swelling there is. In those scenarios, you might have to place an earwick. And the earwick is going to kind of span that space and also allow for the medications to kind of run through it and get into the area of injury proximal to that obstruction. But the key thing is going to be antibiotics. And it's going to be, again, topical in this case. You're going to be giving otic antibiotics. The one that you want to consider is neomycin, which is an aminoglycoside, polymyxin B, and hydrocortisone. These are going to be for patients who have otitis externa, and it's going to be really good at eradicating primarily Pseudomonas. And we'll talk about this in a second. This can't be given if they got a ruptured tympanic membrane. All right, we'll talk about that in a second. But again, it's going to be very helpful because the steroid will reduce the edema, and the polymyxin B and the neomycin will eradicate the pathogens. All right. The ciprofloxacin and the dexamethasone is going to be doing the same thing, except this one is the one that you give if they do have a perforated tympanic membrane. So again, when you do your otoscopic exam, you want to note, do they have a tympanic membrane perforation, right? Another thing is if I can't see the tympanic membrane, I'm going to consider it's perforated because again, I run the risk of ototoxicity if I give them the neomycin. So if it is perfed or if I can't confirm that it's actually normal, in that scenario, I'm going to give them ciprofloxacin and dexamethasone because it's not ototoxic, right? If they don't have a tympanic membrane perforation, I've completely confirmed that, then I will give them neomycin and polymyxin and dexamethasone. The reason why is neomycin carries the aminoglycoside capabilities of causing ototoxicity, and they can lose their hearing. So that's really important to consider, all right? Avoid neomycin if there is that perfed tympanic membrane or you can't actually confirm if it's perfed or not. All right, acute otitis media. For this one, it's still going to be pain control, right? That's going to be first thing. And sometimes we then have to decide whether or not we're going to do antibiotics for these patients. Again, it's an infection primarily in the pediatric population, so there comes with some potential things that we have to discuss. Amoxicillin is probably going to be a really, really common one that you're going to see across the board here. All right. It's going to eradicate Streptococcus pneumoniae. It's going to eradicate H. flu. It's going to eradicate your Moraxella catarrhalis. Another one that we consider in certain scenarios in which the patients had recent like antibiotics or they have other risk factors that make me concerned that they're not going to respond well to amoxicillin, I may go to Augmentin, which is amoxicillin clavulanic acid. In certain scenarios where a patient has an allergy to penicillins of sort, you may go with oral cephalosporin. So that's an alternative that we'll talk about. You always are going to want to try to prefer the oral route as compared to the intravenous or IM route. And then again, in certain scenarios of very, very concerning penicillin allergies, you may go with the azithromycin. The big thing here is that we want to try to stay away from azithromycin because you are getting species that are becoming resistant, especially strep pneumo, especially Haemophilus, that's becoming to azithro. So this really should be kind of really for the case when there's an anaphylactic reaction to any kind of like amoxicillin or Augmentin kind of. So they had a penicillin allergy that's really, really severe. All right. The next thing is tympanocentesis. For acute otitis media, we don't do tympanocentesis unless the patient is just really not getting better and we can't figure out why they're not responding to antibiotics. You don't do this all the time. So tympanocentesis is really because they're just not getting better and I want to test the fluid to find out what kind of pathogen is there to direct my antibiotics. So again, it's really just going to help to guide antibiotic choice, but oftentimes you're going to cover it with this, but if they're not getting better, that's when you may kind of push to do that. All right. So tympanocentesis essentially is what it sounds like. You're sticking a needle directly through the tympanic membrane. When you puncture through, you're doing that to access that actual fluid, to test it, send it off to the lab, and figure out if there's any particular pathogen and which one is going to be the concerning one. And is there any antibiotics that are sensitive or resistant to it? All right. In acute otitis media, in certain clinical scenarios, And we'll talk about this in a little bit as we go through this step by step. Myringotomy, which is you're cutting the tympanic membrane and you're shoving a tube in, is for patients who carry this persistent, like recurrent acute otitis media. They have recurrent effusions, and it's getting to the point where they are actually having hearing loss that is affecting their ability to advance their language. They're having language kind of disparities. In those scenarios, we usually push to put in tubes. So recurrent acute otitis media that's really starting to affect them, that's when we would do this. That's really, really important. And we'll talk about this. So again, what you're doing is you're basically what it sounds like. You're cutting a hole there. You're going to be shoving a tube into that place, and it's going to allow for the drainage of any of that fluid, whether that's a serous fluid, whether that's infected fluid. And again, you're trying to make sure that you're not causing this consistent fluid buildup that's leading to hearing loss, that's contributing to their speech, kind of like not advancing their proper speech. All right. So that's really, really, really critical for us to remember. Now, a lot of the times when you do these for these patients, you don't have to do a tympanocentesis. If you ever cut in and put a tube in, you're going to culture from that, and you don't need to do a tympanocentesis. That's another thing to remember for this if you got to that point. All right, cool. This is a lot of information. So what I want to do is I want to put this together in a very systematic plan. So because when you're presented a clinical scenario, you need to know, which one am I going to do, dude? You hit me with a lot of stuff. I got you. All right, let's kind of go through this, because a lot of the times you probably just say, it's antibiotics, that's oral antibiotics. And you'd be right. That's the case for most of those scenarios. But what about the scenario where the patient develops complications, right? That's when we start getting into the needing of IV antibiotics, right? Which we'll get into. But again, for the most part, you'd be safe in saying there's specific antibiotics that I'm going to give this patient and we would expect them to get better, all right? These other things that we talked about really comes with only specific clinical scenarios. So let's kind of evaluate that. Let's say that I have a patient who has acute otitis media. The first thing is, do they have indications for antibiotics? That's another thing. We didn't even talk about that. All of them are getting supportive care, but only certain patients are getting antibiotics. What are those indications? It's really particularly in the pediatric population that we ask this question. In adults, they pretty much get hit with antibiotics. For pediatrics, we really need to be careful. So the first thing is, are they really, really young? All right, less than 6 months, they're going to get antibiotics. If they're 6 months to 2 years, right, and they got bilateral acute otitis media, they're getting antibiotics, right? If they have a very high degree of pain and their fever is also pretty high, they're getting antibiotics. If they're immunosuppressed where they won't be able to fight this off on their own, they're getting antibiotics. If they have a tympanic membrane perforation, that is a severe case. We need to give them antibiotics. And then lastly, if they have a cochlear implant, you're like, what? The reason why is with cochlear implants, especially since strep pneumo is a common pathogen, it can use the cochlear implant as an opportunity to get to the meninges and cause meningitis. And so that's a really, really important one. You want to prevent that. So that's why that one comes up. If they don't have it, you're just going to treat them with supportive care and they should get better on their own. Most cases will. But if they have these particular clinical scenarios, or they just don't get better. So it's not just that being an indication, but they also just don't get better. So you do supportive care and they don't get better, you're going to be giving them antibiotics. But you got to then say, okay, all right, I've done this. I've gone through, they're less than 6, they're 6 to 2 months with bilateral, they're immunosuppressed, they got a perf tympanic member, they got cochlear implants, all of these things, or they just didn't get better with supportive care after 2 to 3 days. I'm going to give them antibiotics. But the antibiotic choice comes with the penicillin allergy question or not. So do they get a penicillin allergy? Because if they don't, well, then what do we say? It's amoxicillin or clavulanic acid, which is added on. The question that comes is, which one do I choose determines if they've had recent antibiotic use. That's probably the most common thing that they're going to present is they'll say, oh, you have a patient, maybe this is a 7-year-old patient, they have acute otitis media, but they were treated with amoxicillin about 14 days ago for something. Okay, then this isn't going to be the one. They could have had an opportunity to have resistance. I'm going to go with augmentin. But if they haven't had that, then you're going to be okay, and you can just do amoxicillin. All right, so that's the decision process that I want you to think. If they do have that penicillin allergy, it comes down to, is it severe? So in other words, is it a type 1 reaction or a type 2 reaction? I'm sorry, a type 1 reaction or not. So type 1 is anaphylaxis. If they do not, and they just get like a rash or hives, you'd be okay going with an oral cephalosporin, right? If they do have an anaphylactic, a type 1 reaction, you don't want to give them a cephalosporin because there's like a 3 to 10% chance of cross-reactivity since they have that beta-lactam ring. And that's when you would go with something like azithromycin, right? Now, from here, this is how you would pretty much get most of your patients and you'd be good to go. You don't need to go any further. But let's say that, and again, this is just pointing to the point of why we try to avoid azithromycin. We really only want to use it when we need to. But let's go to the point where you're trying all these antibiotics, depending upon which allergy they have or not. You want to know, is it working? If it is not getting better, that is a concerning issue, right? And so are they not getting better? All right, no, they're not. Then I'm worried that a couple things. The antibiotics aren't covering this, or there is a complication of sort. So what you do is you ask the question is, do I need to adjust my antibiotics, right? And so if you are adjusting your antibiotics, and then sometimes you may also ask the decision is, are they getting worse? And do I need to, so they're not getting any better. Do I need to do any imaging? Did it spread? But also we need to know which antibiotics to adjust with, right? So you may do that. For example, you may, if they're on amoxicillin, you may go to Augmentin, right? If they're on Augmentin, you may go to a cephalosporin, right? Those are things to consider, right? But if they do all of those things and they don't get any better, right? No improvement, or they're on azithro and they didn't get any better in general, then what do? You got to ask yourself, is the pathogen that's there resistant, or do I not have any idea what the heck is going on? That's when I would do a tympanocentesis, right? Because it's then going to help me to truly pick the proper antibiotic, right? If they are getting better, all right, and the symptoms are improving, well, then the next question I want you guys to always ask though, do they keep getting recurrent acute otitis media? Do they keep getting effusions? And now they're having hearing loss that's affecting their speech process. If the answer to that is yes, you need to refer them for a myringotomy with tube placement, all right? Because you want to prevent those effusions from consistently causing the risk of them having hearing loss and then slowing their development of their language. That's really, really important, all right? That covers this, and we really hammered into this one. And again, I'd say that you'd probably be safe just knowing this top part here, but we took it a little extra because we're ninja nerds, right? All right, let's move on to the next component here. Cholesteatomas. Cholesteatomas are actually pretty straightforward. Unless they really have obvious signs of infection, it's a surgical intervention, right? So it's a tympanomastoidectomy. So basically what you're going to do is you're going to do a tympanoplasty, which is you're going to repair the eardrum and the ossicles if they need it. And then you're going to remove the cholesteatoma and any of the actual cholesteatoma that's in the mastoid sinus, cut that thing out, and kind of, depending upon which type of like mastoidectomy you do, that kind of guides that. So essentially that's really important to remember that when we think about this patient can have a cholesteatoma that's really maybe involving this middle ear. It's eroding the bones. It's kind of extending into the mastoid. What we're going to want to do here is think about this, right? Let's say here we have a cholesteatoma, and you can see how extensive this thing is. What we're going to do is we're going to probably cut out this cholesteatoma. And then when we cut all of this out, you're probably going to also remove the mastoid kind of air cells and probably open it up into the external ear canal. That's the most common one, which is a canal wall down. There's a canal wall up approach, but the canal wall down has been shown to have a lower recurrence of cholesteatomas. But we're going to open that up into the external ear canal, get rid of a lot of that mastoid air cells, and then on top of that, repair the tympanic membrane and then repair the ossicles. That's what a tympanomastoidectomy is done with, right? And again, there's two different ways: canal wall down, canal wall up. Canal wall down reduces the risk of the recurrence. The canal wall up preserves your general anatomy, where this isn't opened up into the external ear canal, but it does have a higher risk of cholesteatoma recurrence, which is, again, important to consider. All right, mastoiditis. So again, if a patient has mastoiditis, so they start off with acute otitis media, it then spreads into the mastoid sinus, they get a mastoid infection, they get that kind of post-auricular tenderness and swelling, pushes the actual ear outwards. That maybe is enough to diagnose mastoiditis. Sometimes you get some CT imaging if there's any kind of inconclusiveness, if there's any concern, that's a possibility to get a CT scan. Once you've diagnosed this, the antibiotic regimen changes a lot. So IV antibiotics are going to be the preferred way to go, because you have to think about this. This is involving like bone now. And so it's kind of like, if you want to think about it, it's kind of like an osteomyelitis. And that's why this is important to consider. So that's why sometimes CT imaging is actually going to be a go-to. But this is really going to be eradicating Streptococcus pneumonia, Haemophilus influenza, Marexia catarrhalis, and any kind of anaerobes that can also have spread to this area. All right. The only time you'll also do an alternative is like maybe IV cefepime, piperacillin tazobactam. That's if they have some really resistant types of bacteria, right? And this is going to be in certain clinical scenarios that we'll discuss, all right? Especially like Pseudomonas, that would be one to consider. IV vancomycin is really only if they have MRSA risk factors. And then tympanocentesis is pretty much every one of these patients, it's necessary. You actually should get a tympanocentesis if they have a diagnosis of mastoiditis. And then myringotomy with tympanostomy tube placement. This is going to be, again, something that you'll probably most likely do with these patients. And again, I would say this, that if you're doing a myringotomy with tympanostomy tube placement, you don't got to do a tympanocentesis. But again, this is something that you'll do to drain the infected middle ear fluid, improve the actual aeration, and really help to kind of clear up that mastoid sinus. But sometimes even all of these things fail, and you got to do a mastoidectomy. And that's removing all of the infected bone and drain, if there is any abscess, getting all of that out. And it's going to become one big coalescent kind of cavity without any air cells. All right. That is generally a step-by-step kind of like, what are the treatment options? But let's put it together. So if a patient comes in with mastoiditis, the first question that you want to ask is, have they had any recurrent acute otitis media? The reason why is, if they have recurrent otitis media, they've probably been treated for it. And if they've been treated for it, they've been hit with antibiotics. The antibiotics have an opportunity to cause the bacteria to develop enzymes that make them resistant to it, right? Or if they've gotten recent antibiotics. In those scenarios, that's really important because that guides the decision-making process. Are we going to give things like this in the standard case? Or are we going to give things like this in those resistant cases? So if they do have this, that's when you're going to go with your piperacillin tazobactam. If they got the risk of MRSA or they look like they are going to die, you'll add on the vancomycin. If they don't have any of these risk factors, then what will you do? You'll probably be fine with IV ampicillin sulbactam. Now, with all of these patients, you're probably going to have to at least ventilate the middle ear. And that's going to allow for proper drainage out of the mastoid sinus as well. You got to get that fluid out of there. And so that's when you're going to do the myringotomy with the tympanostomy tube. So again, that's why sometimes if you're doing this, you don't need to do the tympanocentesis. That's an important thing to remember, okay? Once you're doing that, you're draining, you're ventilating, and you're helping to kind of eradicate that infection. But the question then comes, are they getting any better with these therapies that you've instituted? And another question that you should ask is, do they have any kind of extra, let's say, spread beyond the mastoid sinus or spread beyond the middle ear? In those scenarios, for example, like a brain abscess, you can no longer allow for this patient to go with the myringotomy with tympanostomy tube placement and just antibiotics. Then you got to cut this thing out, right? So that's the question that you have to ask. If they are getting better with antibiotics and there is no extension beyond the actual mastoid and the sinus area and the middle ear, then you're probably okay to just say, let's go to oral antibiotics based upon the culture that I got from the myringotomy. When I did that, I collected some fluid, right? If not, then what are you doing? You're going to be cutting out that dang infected mastoid. So that's what I want you to remember. Risk factors, yeah, go with the aggressive antibiotics. If not, go with IV ampicillin sulbactam. Add on a myringotomy to drain the middle ear, really help to ventilate it, and help to drain the mastoid. Don't get better, or it extends beyond the actual mastoid sinus. Okay, cut that thing out. It does improve, switch to oral antibiotics based upon whatever the culture came back with. That's what I want you guys to take away from this. One other thing to remember is that because acute otitis media, it can cause mastoiditis, right? It can cause cranial nerve 7 palsy, or it can even cause bacterial labyrinthitis. The treatment would be the exact same for a patient who had bacterial labyrinthitis. The only thing that you're probably not going to do is like a mastoidectomy. You're not going to do that. So that's one really important thing to remember. In the scenarios where it did extend to the central nervous system, that's a very specific antibiotic regimen that you'll put them on, which we talked about in that CNS infection lecture. So go watch that if you guys need a real quick recap. So we really went into a lot of detail on mastoiditis, which again, I think it comes down to just, you need to know the antibiotics. It's just IV is really the big thing. Unison's probably going to be your go-to. Know the myringotomy with tympanostomy tube is pretty much required, and just know if they're getting better. If they're getting better, cool. You can advance to oral antibiotics. If they're not, you may have to cut out that mastoid sinus, right? So that's the big thing. For malignant otitis externa, this one, again, it's the same thing. It's just, it's important to ask yourself the question, do they have some really severe presentation or a lot of risk factors where this thing can get worse really quickly? If they don't, you can probably be okay just giving them oral ciprofloxacin because it's going to cover the most common pathogen in the scenario like Pseudomonas. But in more often than not cases, the patient's going to need double Pseudomonas coverage. Oral Cipro plus another Pseudomonal antibiotic. So ceftazidime is one, cefepime is another, or piperacillin tazobactam is another one. So that's where you have to ask yourself the question, is there any skull base extension? Is there seventh nerve palsy? Do they have immunocompromised state or uncontrolled diabetes? If the answer to that is no, then you can probably just do oral Cipro, All right. If the answer to that is yes, then you should do oral Cipro and add on an anti-pseudomonal antibiotic that is IV based, whether that's cefepime, ceftazidime, or piperacillin tazobactam, because you really want to get enough pseudomonas coverage. And that is what I want you guys to think about. Now, when you're doing these, get the culture first, because it's going to help to guide the oral antibiotic transition eventually. Because just like mastoiditis, they're going to be on antibiotics for a while, man. Sometimes 2-4 weeks. Same thing with this one. They'll probably be on antibiotics because it's like an osteo, essentially. If it extended to the skull base in these scenarios, you're going to be on antibiotics for a decent amount of time. And so that's really, really important. So that's why it's really, really critical. When you treat them with oral antibiotics or IV antibiotics, it's important to remember you can monitor their ESR and CRP. This is based upon up-to-date evidence. But again, I wouldn't always bank on this. Just go off of clinical symptoms as well. But again, if the ESR and the CRP are kind of continuously in this scenario dropping and their pain is improving, then you can just continue the ciprofloxacin, right? If their ESR is continuing to rise, their CRP is rising, their pain's not really improving, that's when you got to repeat the imaging, assess the extent of damage, and you may have to do a surgical intervention. You may have to debride a lot of the actual destructive tissue. All right. Ooh-wee! That was a monster lecture on ear infections. And I really, really hope that at the end of this, you feel confident. I hope you guys understand it, you know it. And whenever the test comes, whenever you guys are asked questions on the boards or in the wards, I feel like you guys feel confident and able to take this on. So, man, thank you guys so much for watching. I really appreciate you guys so much. And I love you guys. And thank you guys. And as always, until next time.